Hello, everyone. My name is Tahirah Jarrett, and I will be your moderator today. Blaine, please let me know when we are ready to start.
We are ready to start.
Okay. Hi, everyone. Welcome to today's event. Hope everyone is well. I'm going to start off by introducing everyone here today. Right now, I just see your name. I'm not sure if you want to put up the PowerPoint. But want to introduce everyone today, starting with Gina. Gina has worked as a labor and delivery RN for the past 12 years at the New York City Medical Center here in New York. And Gina was the first to introduce the wonderful world of L&D as an RN. And she also has a passion for women's healthcare and is an active member of the Black Mothers Matter and Labor Support Committee here at NYU. And then we have Karina. She started off as a labor and delivery at NYU, Langone. Her pronouns are she, her, and she's the proud daughter of immigrants and dedicated Afro-Caribbean and Black nurse, a forever learner, and one of the founding members of a current cohort of the Black Mothers Matter Committee. And then we have Helena. Hi, Helena. And she's the director of the midwifery at the NYU Langone Hospital's Health and Hospital at One Full affiliate. And she's a certified midwife. And then we have Patricia. And Patricia is a certified nurse and midwife. And she's a service director at the Harlem Hospital Center. Blaine, would you like to put up the PowerPoint? So today we'd like to talk about the disparities in the health industry and how we as Black women can continue to exercise our voice and exercise our power as we navigate these spaces. And we want to start off by introducing Allison and why we are here to do this. So Allison, we'll start off with you.
Sure, thanks Tahirah. Hi everybody, thanks so much for joining us today for this really exciting and interesting webinar on maternal health disparities. This event is part of the YWCA's 15th annual Stand Against Racism campaign. Local YWs across the country are hosting events focused on a myriad of racial justice issues that impact the health and safety of communities of color. And this has been, as we all know, a really big week in the fight for social justice in our country. We're just 3 days out from the verdict in the Derek Chauvin case, and it is encouraging that accountability for the unjust and cruel killing of George Floyd has been established. But we know that there is so much more work to be done in the fight against systemic racism in our country. Stark and persistent disparities in maternal health are an important manifestation of the systemic racism in America. And today, we at the YWCA of New York City are honored to be joined by 4 women who are maternal health practitioners, you just were introduced to them by Tahirah, and activists in the Black Mothers Matter movement. I look forward to a really lively discussion. The YWCA of the City of New York remains dedicated to our mission of eliminating racism, empowering women, and promoting peace, justice, freedom, and dignity for all. And we are committed to the personal and social development of women, their families, and their communities. With that, Tahirah, I'll turn it back to you, and we'll get going with the presentation. Thanks so much.
Amazing. Thank you so much, Allison, for that amazing intro there. So we're gonna have Gina start off and kick off with the PowerPoint and the conversation.
Blaine, can you share the PowerPoint? And Karina's going to just start with the beginning, and then we're going to go from there.
Thank you.
Thank you so much for the introduction. I'm Karina Hernandez, and I just want to start off before we dive into the PowerPoint saying that this is a safe space and this is a very heavy topic, so we encourage you that if you do need a break, please take one. It's also hard for us to not get caught up in the statistics, and we have to remember that while the numbers might enrage us, we have to acknowledge that we are talking about women and Black birthing people. And so Gina is also going to touch on the historical roots of obstetric racism. So again, a heavy topic. Take breaks and let's remember who we are talking about here. So the Black Mothers Matter Committee was started at NYU in the spring of 2019. Gina and I were one of eight labor and delivery nurses that started this in response to the Black maternal health rate in New York City specifically being incredibly disproportionate when compared to non-Hispanic white counterparts. And we hope to cultivate a culture of safety and satisfaction for Black, Indigenous, and birthing people of color in New York City. We have a grassroots approach to cultural awareness, and our main mission is to emphasize the importance of recognizing and immediately addressing any degree of discriminatory practices that hinder patient safety. And our focus is really to continue the conversations around obstetrical racism. When we won the 2020 award in NYU for innovation, we stated, Black Lives Matter, not just yesterday, today, and tomorrow, but always. So while this is quote unquote a timely issue, this is not new. And we want to acknowledge that there is much to be done and undone. We could go to the next slide, Gina. You're muted.
Thank you. I want to talk, and like Karina said, this is a really heavy issue. So if you do need to take breaks or just tune out for this portion, fine. So I just want to talk about a brief overview of the 400 years of sexual and reproductive health experiences of Black American women and people. And racism is pervasive in all the experiences of Black people in this country. So I want to start with 1619, when people were enslaved. There were public nude physical auction examinations. There was legal sexual assault of women, and they were raped for sexual pleasure and economic purposes. Enslaved women were denied their reproductive rights, and their reproduction was intrinsically linked to an economic system. And we know that there were non-consensual GYN surgeries performed on enslaved women without anesthesia, even though anesthesia was available at that time, just to perfect the technique of the surgery. And a lot of that was done by who some consider the father of modern obstetrics, James Marion Sims. And that takes us into the 1800s, when there were Black Code laws and Jim Crow laws. And Black Code laws just generally restricted the advancement and migration of Black people following emancipation, while the Jim Crow laws restricted overall civil rights. There was poor or no health care for impoverished women, and there was compulsive sterilization at the time. And then we get to the civil rights era of 1955 and the post-civil rights era of 1975, where there were overt and subtle forms of racism in the US healthcare system. There was legal segregation of healthcare until the passing of the Civil Rights Act in 1964. And during the time of civil rights, there were federally funded programs that were supporting forced sterilization of Black women, with Black women being threatened or denied termination of their welfare benefits, or threatened not to receive health care if they did not consent to sterilization. During that time, there were Black exploitation movies, hypersexualized imagery of Black people, and continuation of generational poverty, unequal health care, and sterilization. And that takes us to the present day, where we continue, to have race-based residential segregation, continued negative stereotypes and media portrayals of Black people, and ongoing health and economic disparities and disenfranchisement, including our current maternal mortality and morbidity crisis, along with the inequities that were evident during the COVID crisis this year. And I just want to highlight that these disparities exist despite social economic status and education levels. It takes us into our next slide, which is something that as a committee, as the Black Mothers Matter Committee, we feel really empowered to end the mother blame narrative. So we know that there is an inequitable distribution of pre-pregnancy chronic illness and pregnancy complications that affect the reproductive and general health of Black people, women, and their children throughout life. We know that pregnant women and Black mothers have been held solely responsible for the complications of their own health, their pregnancies, and the health of their children. And this narrative has really dictated how medical providers manage pregnancies and attempt to manage disparities in general. But by exclusively focusing on individual behavior as the basis for health outcomes without structural or historical context, we continue to promote stigmatization, scapegoating, heightened surveillance, such as increased drug screening, increased ACS reporting, criminalization, and loss of body autonomy of the pregnant woman. Next slide, please.
So the focus right now, so we stated everything that happens when we don't see these women as full humans and not hear their experiences that they have. So really what's missing is that we need to shift the narrative. So while the current narratives, most research has stated that the greatest contributor to neonatal health outcomes is urine environment and pregnancy exposure, but this really doesn't include circumstances and environments in which these women seek to maintain health, become pregnant, give birth, and parent, and the lack of resources to do so. Most of individual behaviors have been seen to try to understand these disparities, but it really doesn't identify the role of racism and implicit biases that people have that affect health outcomes, where when Black women are sometimes seen coming into pregnancy older, sicker, and fatter. Again, we're missing the full scope of what really is going on here. So the following options are ways for Black maternal health disparities to decrease. So to either birth elsewhere, to go to providers that look like them, who identify with their same race and identity. And there is a huge push, especially after COVID this year, to have providers that are of different backgrounds to take care of people. And birthing at home or with a midwife, or consider to birth at a birthing center, not a hospital. And Gina had mentioned as well earlier in our talks that maybe doing childbirth education early in pregnancy, so they have time to either change their mind about who they want to see, or if they would like anything different in their care, to incorporate that early in pregnancy. And lastly, of course, do your research, talk to women, share knowledge, spread the word, and refer them out to people doing the work, whether they're considering pregnancy or are pregnant now. That's it. Thank you.
Thank you so much for that. You guys do phenomenal work. And I really just want to start off by asking, like, what's your personal journey as to why this was such a prevalent thing that you wanted to work on?
Is that question for anyone?
Yes.
Okay. I first want to thank the YWCA for having us. And I just want to back up a little bit before we go forward, if that's okay.
Yes.
I want to thank Allison for her great introduction to this topic, because I really appreciated her segueing and synergizing the verdict with this topic, because the truth of the matter is they are one of the same. No different than the timeline that was put up. It is a transference of what happens, and an understanding that the racism that Black and Brown people deal with, it starts actually in the womb. And that if we understand epigenetic science, beyond science that we know, we really begin to understand that I am what my mother felt and dealt with and ate, and I am what my grandmother felt and dealt with and ate. And so, when birthing people enter into the space, when there's no recognition of that, and then they live these lives that are extremely weathered lives, dealing with the social determinants of health and these medical conditions as a result of the social determinants of health, and they deal with an environment that is embedded in systemic racism. We have racism in the womb that is palpable, that they feel, to all of these things that were talked about in the timeline, up and until these deaths that happen at the hands of police in what is not a post-racial society in America. And we get to George Floyd and the many other Black and Brown men and women like him whose names could be mentioned in this conversation. So it's a timeline in that way as well. So I really appreciated us starting with that, because the genesis does become the revelation in these conversations, when we want to step into the conversation and tell the truth about that. Just a word on language. I'm seeing the word delivery used a lot. Anybody who knows me, it's a pet peeve of mine. There is no such thing as a delivery. I get deliveries from Amazon. Pizza gets delivered to my house. No woman ever was delivered. That is a patriarchal word. It entered into the medical literature when men took over obstetrics, and women give birth. And so whether you are a nurse, whether you are a doctor, whether you are a midwife in the space, you stand as vanguard to make that journey hopefully holistic and safe. And women birth with you, but you don't deliver them. It's not about what you did. It's about what you stood in the space to provide a safe place for. The third thing, I just want to go back into the introductions. It's Pat Loftman's birthday. And she is a mother matriarch of midwifery in this city. And she was the director of Harlem Hospital. And she is actually now retired. She is not the current director. And then I also want to encourage my nursing colleagues to add midwifery to that timeline that they brought up. That is so beautiful and so wonderful. And to really add how you can actually see when you take out Black and Indigenous and white immigrant midwifery, because the midwives and the original medical professionals that became doctors, did not respect Black people, Indigenous people, Irish people, Jewish people. And when you look at that, and it turns into this very Anglo-Saxon profession, and the removal of midwifery from the care of these immigrant, Indigenous, and formerly enslaved communities, you see the timeline of what happens with maternal mortality and morbidity, with a dissection, if you will, of the trust of having a community provider. And that has to be part of these conversations. And then I also want to say one more word about the mother blame narrative. The mother blame narrative is born out of this non-recognition of the concept of weathering. and about what is actually happening when I grow up in a community that is racialized and minoritized, and that is disenfranchised, and what that means when that happens generation after generation after generation to me. How do I present when I come into the healthcare system? What is that doing to people when they don't have resources and they don't have education? And so I'm going to be quiet because I could talk all day about this, because like this is my thing and my love. You know, when we talk about solutions, everybody, you know, we're talking about the thing as it happens and why it happens. One thing that I talk about a lot is it happens a lot because there is not a firm undergirding of the history of these issues. People came into this profession, whether you're a nurse, whether you're a doctor, whether you are a midwife, because no one's perfect. And there was not an understanding of this historical content about what happened to people. And that I love in the bottom part of your slide when you talked about John Lewis's statement, more needs to be done and things need to be undone. The work is around the consciousness of the undoing, that, you know, quite frankly, many things that people learned about how to treat people that were supposedly good for the patient are not good for the patient, because it doesn't take into the account these issues of weathering, the issues of racialization, the issues of true informed consent, and the issues of providing a holistic experience during what should be this very sacred time. And it doesn't take in consideration patient choice. And so I really firmly believe in all avenues of healthcare education, there needs to be an undergirding history so people can choose to take on these callings with an understanding of these factors. And that needs to be adapted and totally infused and synergized into medical education, so that as a whole unit of collective practitioners, we labor and give birth to a different type of workforce as we go forward.
Wow, Helena, that was a lot. And I can agree with you when you say it starts before, you know, we're even here, right? And it's funny because I was speaking with my therapist one day, and we were talking about childhood trauma and like all the things, and she was just like, ask your mother how she was when you were in her womb, and I bet all the things that you are suffering now is what she was going through. And I went back to my mother, and like for every little thing she said, I was like, oh my gosh, that sounds just like me. And because she didn't have the tools and the resources, or just people in her corner telling her how to journey within her pregnancy, how to deal with postpartum, or how to even conceive, and like all the things, she didn't have a midwife. She definitely didn't know what a doula was, you know, and my grandma wasn't any better. You know, she was an immigrant woman coming from Jamaica with access to nothing. So then it trickles down into me. Like, I just started learning about my body and advocating for it. And I'm about to be 30. So imagine if I wasn't in this space to meet women like you, or have spaces like this to really, you know, learn about what's happening. So I definitely appreciate your work and what you've been doing, Helena. So when you say all of that, right, what would be the next step for you into getting access? If you could do something like right now, what would that look like for you to give access to women who don't have the privilege of getting this type of knowledge or this type of care?
So I'd like to step in here a little bit and just go back into history, because as Helena alluded to, and as both Gina and Karina alluded to, history is extremely important. Now, when we go back into the period of enslavement, keep in mind that midwives were the only individuals who provided healthcare, not only to women, but they were the healthcare provider for the entire community. I mean, they were the mother love, they were the surgeons, they were the herbalists, they were everything. And so after the period of enslavement ends, what happens to these women? For them, this was a calling. And so they remained in the community. I mean, they were the center of the community. They were held in high regard and esteem. They were loved, they were respected. And so you go into the early 20th century, midwives remain and continue to be the center of healthcare. But at the same time now, you begin to have the role of medicine emerging and infiltrating this system that has been in existence. It is a system mostly of men who believe that control of healthcare is their destiny, is their right, is their privilege. And over time, and with the assistance of nurses who look like them, who align with their philosophy and belief, those highly regarded midwives become extinct through deliberate engagement of the healthcare system. They are eradicated, and you then have the synergy of the eradication of the grand midwives, as they are lovingly known, and the emergence of the organized healthcare system that is completely separate from what women have known their entire lives and women have experienced. As you go into the 50s and 60s, the beginning of women entering the hospital, because remember now, prior to the 1900s, everyone gave birth at home. But the medical industry begins to propagate the belief that if you want to have a safe birth, you must now enter this institution known as a hospital. And women begin to believe that a hospital birth is the sole safe birth. At the same time now, you have the convergence of the women's liberation movement. Women are beginning to become somewhat conscious about themselves and their bodies. So you have these two clash of institutions in the beginning of the 60s, as women are beginning to feel a sense of empowerment. But that empowerment doesn't translate to Black and Brown and Indigenous women. That power becomes centralized among white women, and you have the emergence of midwifery. But whereas midwifery was Black, Brown, and Indigenous, it now becomes white. And you have some of the same belief systems. Remember, belief systems emerge in our entire existence, everyday existence. And so this new emerging profession takes that emerging, those stereotypes into this new emerging profession. And so you begin to have a profession that is now entering women's lives, but they're entering women's lives in a way that was not beneficial to women. Because while this is going on, you now have the federal government creating ghettos and creating suburbs. And that history becomes very, very critical when you then have institutional racism as we know today, which is the distribution of resources with residential segregation that Gina and Karina spoke about. We don't really understand until we begin to see residential segregation emerge. You have the emergence of ghettos that are under-resourced, and you have the emergence of suburbs with all of the resources going to the suburbs. And so you then develop these enclaves where people have poor housing, people have lack of adequate nutrition, people lack all of the resources that you need to thrive and have healthy lives and produce healthy women, produce healthy children. And so history becomes very, very important. So what we really want to do is change the narrative. So rather than blame women, rather than saying all of the morbidity and all of the mortality and all of the poor outcomes that we see is because of what women are doing, what we really need to say is, what do we need to do so that at the end of their journey, women have healthy outcomes, healthy babies, women themselves are healthy. What is it that we need to undo so that women have lives that thrive, so that they themselves can then thrive and have healthy children? And one of those options is now the emergence of Black, Brown, and Indigenous women who are midwives, who were Black, brown, and indigenous women before they were Black, brown, and indigenous midwives, who come to midwifery with a history that says, I know exactly who you are because I am that woman. I know the journey that you have traveled because I have traveled that journey. I know the hurt that you have experienced because I too have experienced that. I don't know any midwife of color who has not experienced racism in their life. And with that, you bring your entire lived experience into that arena. And that's what women need. And that's how women thrive.
I just want to say, the nuance, I'm a big person who's into etymology and language and what it means and how energetic conceptualizations happen based upon the things people say. So, when Pat just talked about it not being about what the woman is doing, the question needs to be, what happened to her? What happened? What happened that she then presents herself in this time, in this ecosystem, in this way? And what are we going to do about it? So not about what she's doing, what happened? Looking at what happens will really take people on a journey of unpacking that most people don't want to do, but that they should hopefully at some point be willing to undertake.
Yeah. Well, how do you?
Yeah, I'm gonna very take 10 seconds to share an experience that I had with another wonderful midwife named Betty Carrington. But back in the 80s, when crack was really ravaging Black women, we were taking care of those women. And we were able to connect with them in a way that was meaningful, not just for us, but for them. So that after 10 years of taking care of those women had outcomes that would have rivaled anyone who had never touched a substance. And what was valuable for them, because remember, when you render care, the care has to be valuable for the woman. It doesn't have to be valuable for the provider, although it can be. The goal is to have women have an experience that is not only safe, but is so satisfying that they remain with you throughout the remainder of the time that they need healthcare. And so to see women over a 10-year period emerge from an experience that should have devastated them and created a poor outcome for their children, and we didn't see that, we learned that it is what we bring to women that makes a difference.
Yeah, that's really important. I wanted to ask, what was the biggest issue for you dealing with these disparities and the racism and taking that baggage back home? Or how did it affect you mentally, physically, and emotionally, knowing that you were actually doing the work and the healing and the contribution to someone's better journey? That's for anyone that wants to answer.
There's no question that when you create a protective environment for women, it generally is at the expense of your emotional and physical well-being. Because keep in mind, you are part of a system that has not been designed to entertain creating a protective environment. It's really interesting. Often women would present to the hospital and people it would seem as though they were adversarial. Walk through the door and already she's ready for a fight. And what I always had to remind the staff, my colleagues, was that we don't know what these women's experiences were like before they touched you. And so they are bringing their entire historical healthcare experience into that space where you now are. They don't know you, but what they are communicating to you is that they don't believe they are entering into a safe space, and they're getting ready to protect themselves by creating an atmosphere that says, this is adversarial and I'm ready to fight. So again, it's the environment that one creates that promotes the health and well-being that women receive.
Yeah, amazing. And I mean, Gina and Karina, like, how do you guys feel? You know, same question to you guys. You know, you've built this amazing platform. What's your journey like with all like the racism and the disparities and such as you guys are building and unpacking and unlearning?
We had an experience where we learned of a mom who had who actually died in the postpartum period. And that like heavily influenced the creation of this committee for us. We started to just question like things that were happening within the hospital. What were our cesarean section rates? We started to just look at the hospital and really wanted to create a solution for moms and for people who come to birth at the hospital. By first just addressing implicit bias and looking at our own data internally and seeing how what was happening within the hospital so we could start to affect change.
Yeah. And how would you say the leadership of the hospitals, what were their responses to that? Like, how did they counteract what you were feeling with that particular experience?
I could answer. I think at first, you know, nobody wants to have these conversations out in the open, and we have to acknowledge like we do work in a very organized institution. It's a system within and of itself. And so change is always hard, but I think our narrative was always, we need to keep having these conversations. So while it's slow moving and there's a lot of red tape and things take time, there is the backing there to make change happen. And for us, and for me, you know, this has been a personal issue. And I remember saying, you know, right now, as a labor and delivery nurse, who is still working as a labor and delivery nurse today, if I was to go give birth in a hospital and you ask me if I'm afraid to give birth, I mean, the answer is absolutely yes, you know? So I think it's always been about trying to make that better. And I was there when my sister gave birth and I saw it happen and people weren't listening to her and listening that she was in pain. So this happens all the time. And I think it's remaining cognizant of saying we have to listen to these women. And so for me, when somebody comes from outside hospital care, whatever it is, it's what is happening to her. And we need to ask her, does she have help? And who hasn't helped her along the way? So I think those questions are a lot more important than saying, oh, we need to drug test her, or, you know, any of these other things that happen. And all of that is kind of the noise that sometimes actually gets us further from recognizing that the core of the issue is racism and our own implicit biases that we all have, you know, and again, this is a process. I've always said this, you know, I like have privilege as an Afro-Caribbean person and as a lighter skinned Black woman in this country. And I acknowledge that, and it's difficult and it's a process, but it's a process for everybody. So that's not an excuse, for example, to not do the work.
Yeah, there's a lot of unlearning to do when it comes to representing ourselves and showing up for ourselves in the hospitals and going to the doctors. And even for myself, again, I've now been more audacious and I go in with more questions. And I am glad that we have things like technology and the internet to really shine light on things like this. Like, you know, I didn't learn about the history of Black women being test dummies almost, you know, in the beginning stages of gynecology until my late 20s. And these are the things, like, you know, Helena and everyone has been saying, that we need to start with the children. Like, we need to start young, and we need to go into like these neighborhoods that don't have that access. So this is a question for all, like, what's next? Like, how are we really going to make the change? We have these discussions all the time, but what are we going to do now?
I think, go ahead, Pat.
Well, I think one of the things, what we're doing right now, I think is very valuable, because women are beginning to learn, number one, that they have options. That's the first thing. Beginning to transmit information to women, not only that they have options, but what those options are. Many women think that the only option that they have is to receive their health care in a hospital setting, and that is not necessarily true. They have questions about, how do they navigate the healthcare system, and who can be there with them to advocate for them. So the first part is just to make certain that women have the information that they need, so that they can then make informed choices for themselves. So that would be the place to start.
I think what we do now is continue to tell the truth in all spaces that we're in. Tell the truth and, really, find a space between grace and accountability, and live the expectation of people changing behaviors, and also provide the education that people need to change. There is a big movement in and around the city, in the state, with implicit bias training, and like it's become so sexy. And I've been quoted as saying, that's really 2018. Hello, we're in 2020, 2021 now. What do we, if we're identifying these issues as racism, why is the training not solidified as anti-racism training? And that really starts with a historical unpacking, because the two need to go together. And I think forums like this are really important, like Pat said, to get this information to the consumer, because there's nothing like self-advocacy and self-knowingness for people to have realizations about what experience should be, so that this kind of blind acceptance of people doing things to you and you not being a part in the decision-making efforts of your healthcare, and then emerging from the experience completely traumatized, doesn't happen. And not just focusing on the statistics, but really providing education to the consumer about how to navigate the statistics. And this is, for me, this is not about blame. This is about self-empowerment. When we move to an empowerment perspective, what we begin to do is to say, well, we want you to be healthy. This is the information we need. We need the information you need. This is what you need to eat. This is what you need to think about. These are the conversations that you need to have. So the work has to be done on both sides, from the health care provider side and from the patient side as well. The patients need to be empowered. And beyond that, even those of us who are in this activist vibration, activation does not just happen within the hospital space. It is about moving it out of the hospital space and taking it to people who have capital and who have legislative power to put things in place to ensure that communities can become healthy and have this knowledge, to put resources in communities, and to be willing to take your activism outside of the hospital space to lend that accountability perspective there as well.
Yeah, I agree.
Yes, let me just add one thing as an example. We throw words around like institutional racism, and people think that they know what that means. And even I, in the beginning, talked about the distribution of resources. So I always give the example that when we advise women to eat well, people don't understand where people's their dietary history comes from. And so when people look at Black women's history in terms of what they eat and why they eat, I always ask people, do you know, people begin to have now coined the term slave diet. And what is a slave diet? I don't know that anyone knows what a slave diet is. What we do know is that the foundation for Black culture and Black diets is, well, what do people always talk about? The beginning of the new year, people eat pickled pork. Where did that come from? All of that comes out of the period of enslavement when we had to make do with what we had, with what was left over, and how it was seasoned to make palatable. Because were it not for that diet, we would not have survived the period of enslavement. And that has intergenerational history that is transmitted through generations. So to now tell people to change their diet, what you're saying to them is to discard that part of your history that sustained you and maintained your family lineage to 2021.
Yeah.
That's what anti-racism training does. It provides the historical context for everything so that you have an understanding of why people are eating what they're eating and why they can't give it up. Because in everybody's culture, diet is the central thing that brings people together.
Yep.
And so if we can't get rid of that diet history, then what is it that we need to do to say to women to mediate the effects of that? That's what anti-racism training does. It's inside, it's outside.
Yeah, and I feel like during this pandemic, we all, as Black and Brown people, we got to realize what's not good for our bodies, because people were dying from the same foods and the symptoms that we're used to. You know, like I just learned that I have slight PCOS, and not knowing what that is and why it's linked to, you know, being pre-diabetic, and from the foods and the cultural things that I've been exposed to is the reason why my body is growing in ways that it's not supposed to. So I definitely agree with what you're saying. Like, you know, we have the unlearning of just like, what? Like for generations and generations, I've been eating oxtail and rice and peas, and that's what's killing me, you know? And we don't know to ask these questions. We don't know to go before it's too late. So I guess another question for everyone is, what are those specific questions you would empower people of color, women of color, to ask when they go into these spaces? Gina, Karina?
I would just say the biggest question to ask is why, and then get an answer that you can leave with feeling totally comfortable, and keep on asking why until you are comfortable with that.
And if you can't get an answer, then that's not the person who should be taking care of you.
Exactly.
I like that. We do have a question here from the chat, and then I'm going to open up the floor to any questions that the audience may have or concerns for the panel. Here we go. Someone brought up weathering. Okay, so from the patient experience perspective, I believe that the patient's voice is imperative. Having the BMMC committee conduct monthly reviews of complaints and grievances that involve AA women in labor and delivery and postpartum, regardless of the gravity, and share the feedback with the unit leadership. I guess you can speak to the best practices of re-education to hopefully prevent future occurrences. So they're just asking, like, what would be the best practices of the re-education aspect of it?
As a committee, we were able to partner with Dr. Karen Scott from UCSF in her, she's evaluating an obstetric racism implicit tool, a tool for evaluating obstetric racism in hospitals. And it, I feel like any hospital that has the ability to partner with Dr. Karen Scott going forward, she's going to offer, now she was validating the effectiveness of her tool. She's going to go forward in working with hospitals to actually utilize her tool and work with the hospitals everywhere where somebody's going to have an experience within the system, from the security guards to the food service people, everybody, to utilize her tool, interviewing Black women and patients who delivered in families, utilizing that tool, see how the hospital is doing, and then recommend an implementation. So I think that we can work with Black researchers who are trying to develop solutions as institutions, even if it involves like a financial, I mean, especially if it does.
Yeah, there is an Indian researcher. Her name is Saraswati Vidam. She's a midwife out of British Columbia in Canada, and she's actually done some work looking at women's experiences in hospitals. And what she has found, especially among Black and Brown and Indigenous women, they said that their response was that the bulk of their experiences, their negative experiences, centered around, and this is the women's belief, centered around race, but also centered around the form of payment that was used for their obstetrical care. And for most of those women, it was Medicaid. And so they felt that they were not listened to, they were ignored, they weren't seen. And all of that had to do mostly with race, but also with forms of insurance. And so I think any institution that really wants to change the culture shifts come from leadership, and leadership at the very, very top. And so if there's a buy-in with leadership from the top, the culture change will filter down to the very basic level, and that's the person who greets you as you enter a facility. But there has to be a culture change that's based on knowing and validating the experiences that women have had in your specific institution.
I agree. I do have one more question from the audience, and it's to talk about the weathering. So they go, this is a common theme in speaking of systemic racism in all fields, including healthcare and birthing. As a provider of maternal care, how do you prevent weathering from lateral violence, racism from white counterparts, weathering from Black fatigue, from affecting you in the care that you provide to the women to whom you are in service?
I'm going to say that you don't. You can't prevent it. You can't prevent weathering because that's something that is affecting you, that the environment and other people are doing and inflicting. So you don't prevent it. I think that anyone who accepts these callings and wants to do it well, it's needs to be an acceptance that it's going to hurt sometime. And that if it doesn't hurt you, and you don't see things and apply all the things we're talking about, accountability, your voice, the truth of what is, that you're not doing it right. If it doesn't become really palpable to your soul, because this is real, this is historical, and things are not really improving. And if you understand the truth of that, it's going to bother you. So I don't think you can prevent it. What I think you can do is learn something that I was not taught. It was in my journey into other genres that I learned this about, going into some space of self-care for yourself and really creating some things for yourself that no one gets to touch, not your partner, not your children. And really being very dedicated, that same dedication you give to these issues, that you learn how to create a safe space for yourself, so that I don't believe in balance, but you end up in some place of self-harmony around how you can go forward. There's a term called the Black tax. I say all the time, I raise my hand, I'm gonna pay it. People say, oh, you shouldn't have to talk about this because we don't want you to pay the Black tax. Well, I'm going to pay the tax. It is what it is. I feel like I was called to pay it. Some people may not feel as called as I feel called to pay it, and to serve in this way and the many other ways. But somebody has to do it. And it's okay. you know, but it is about creating, you know, this space of harmony for yourself, and all health care providers need to do that. We're taught, no matter what genre of medicine we go into, go and serve and serve and serve. And if that takes on a healing modality for you as well, and you become more holistic in your thought consciousness and the way you practice, to heal, but who heals the healer?
Yes.
And recognize that, you know, you got to create that for yourself. Other people can help you and can honor you and help you with that, but that it starts with you.
I literally just told one of my friends that she's a nurse at NYU as well, and she started studying to do nurse practitioner, and she overexhausts herself, and she's such a nurturing person. I'm just like, when do you have time for yourself? Like, who's pouring back into you? How do you pour back into yourself? How do you feel that wholeness? And I'm like, go get a hotel for one day, get a spa, like leave your phone at home. I watch your dog, go rest, learn solitude, because we forget, and that's how we start to neglect our own bodies, because we are wanting to give birth and do all these things while the world is against us, our workplace is against us, you know, society is against us. It's hard. So I love that you said that, because that's really, really important for everyone in this industry.
Yeah, for me, it's a bit deeper than the body. It's about nurturing my mind, my soul, and my spirit. And you know, that's actually what fortifies the body. And really understanding that, and just willing to be forever educate myself. And as I educate myself, unselfishly and compassionately being willing to educate others as well.
Thank you. I have a question from Mary. She goes, the YWCA has an empowerment and leadership programs for high school age girls in NYC. What would you say to young women who are attracted to the maternal health care or activism as they consider career paths?
I would say welcome. You have a system and a network that is already established to welcome you and provide you with the resources and support that you will need. We certainly would enjoy sharing all of the wisdom that we have learned through our journeys. As Helena said, no one told us about this, but we have learned a lot along the way, and we are more than willing to share that with you, so that you don't will escape some of the journeys and experiences that we have had. You know, I just want to tag along to what Helena said. Self-care becomes so critical and so important, even if it means that you identify those people who are doing similar kinds of work, and you connect with them, and you become joined at the hip, as they say, to provide you with the support that you will need, because there is absolutely no way that you will escape weathering. It will not happen. If you're doing the work and you're doing it well, you will become weathered. So find the space that you need, whether it's making certain that you get your nails done every week, or you get your facial done every month. Whatever it is that you believe you will need to sustain yourself, to continue the work, that's what you do, because you will experience weathering during this journey. You will.
Yes. You first, you always. Ladies, thank you so much for this conversation. I'm just in awe by everyone's journey and everyone's impact and what we're all doing to shine light on us as Black and Brown people. So I can't thank you guys enough for, you know, sharing with us. Please share with the audience where they can find you, how we can support you and uplift you, how we can now create this community and tribe of each one teach one, and let's really do some impactful work. So how can these the audience find you guys?
I'm sorry, there's just a really important question in the chat. I know we need to end, but there's one about Black men. And I don't think men are really being invited into this conversation as much as they need to be.
That's true.
Because, they are, I don't want to say half, but they are a big part of the equation. I don't want to put a number to it. But the question was, how can we educate men about Black maternal health? I think we need to educate men about men. When I get that question, before we can educate men about Black maternal health, we need to educate men about what it means to be a healthy man, right? Because when I know what it is, my own self-health and my own self-care, then that energy, it radiates. I can start transmitting and transmuting it. So we're jumping to educating them about what they can do for this, but we have them in an unhealthy, unresourced space as well. I'm worrying about if they're going to be shot, seeing all this imagery and enter into the space traumatized, and also hearing about this maternal health crisis, also then wondering when they enter into a hospital space if somebody is going to do something to their partner, and then they're not going to be able to protect her. So for any question on along those lines, it's really about educating and creating a holistic space of health for that individual that becomes foundational to educate them about any other topic. It has to really start with them. So there's a lot of work that needs to be done for Black men before we can, start educating them about Black maternal health. And then we will find the synergy. And, just like we talked about timeline and how things move into each other almost organically, that I feel like that will move too. And where people can find me, I always give honor to where I work and who pays me. I'm employed by NYU, but I work at New York City H&H Woodhall. So I have to give honor to both because I'm a person who believes in honor. And so I'm also one of the co-chairs of the Maternal Mortality and Morbidity Committee in New York City. I'm also the vice president of the New York State Association of Midwives. And so, I'm not a big Twitter person. I don't tweet things crazily, and I'm not on Facebook like that. People say I should because I tend to have a lot to say, but Twitter cuts people off. And as you see, I can be quite long-winded. But my Twitter handle is actually the matriarchal midwife, because I am a strong spiritualist. I do strongly believe in the power of women, and that has taken me down a road of spirituality into genres of, feminine and power through history and through worldwide matriarchal systems. And so that's my Twitter handle, but you will rarely see me on it. And, I'm just hanging out here, loving on women in community and families, and loving on midwifery students. And that's what I do.
We love that. Ladies, how can they find you? How can everyone find you?
I'm going to put my email in the chat, and then I just linked in Dr. Scott's study. So we didn't mention the name, but it's a sacred birth study. Black Mothers Matter also has a listserv. So if you want to be part of that listserv, I could add you even if you're not an NYU Langone member. So you could just email me and I'll happily add you to the list and email me about anything. So I'll just put that in the chat now.
I, like Helena, am not on social media, so you can find me. I'll put my email in the chat as well. And feel free to email me. And I just want to say I'm so honored and thankful to even be included on a committee with such amazing women as Patricia Lawford and Helena Grant. It's just so special to me. I learned so much, and just so thankful to the YWCA for organizing this and putting together this panel, and also to our hospital, NYU, for allowing us the time and the commitment to focus on this committee.
And as the elder of this group, I most definitely am not on social media, but I will place my email in the chat, and I would like to thank the YWCA for hosting this panel. It's really important that women have places where they can receive information such as this, so I am thankful and appreciative.
Yes, thank you, Allison and Blaine, for having us and creating this safe space. I hope that you have many more of these and your community continues to grow in love and light. Thank you guys so much. And we're closing the chat now.
Thank you.
Alrighty.